get the acute response offered by ketamine, but then be able to extend it? Because the data I'm familiar with, when you look at the use of ketamine, its effect tends to wear off after like a week or so, in treating the depression or depressive symptoms. So this would be a means to extend that treatment effect over a 6-week period.
Well, yeah, I've seen people try to do that for major depressive disorder. They've started, SSRIs or other antidepressants along with starting the ketamine so that you can get rid of the depression immediately, and then after a couple of weeks, hopefully the SSRI kicks in. In terms of bipolar depression, again, I think it needs study, but, I agree with you. It's an anesthetic. More and more studies are coming out, not just, for ketamine specifically, but all anesthetics that they may have, even if you don't see it right away, that cumulative doses may have long-term cognitive effects on people. So, right, I certainly agree. You can't dose someone with ketamine forever. So trying to find a combination that could reasonably extend out that treatment effect, because you're right, it does tend to wear off within a week or two without a repeat dose. So finding some combination that could extend it out, yeah, of course, that would be amazing. And if it worked for bipolar depression or even major depression, that would be great, because then you get that rapid relief and then continual relief. Because right now the regular medications by pills are so slow for response.
Okay. Do you think that
definite market? Yeah.
Do you think that uptake or utilization of such a regimen would be, hampered or somewhat dependent on whether ketamine was ultimately labeled for use in major depression? Like you mentioned that a lot of hospitals are, not using it today, and part of the reason might be because it's not, FDA approved. And I'm wondering if, this study were done, if it would take, a label-enabling study whereby ketamine's label was changed or amended or whatever to drive use of such a regimen. Does that make sense?
Yeah, no, it makes total sense. So, here's what I would say. I would say that, of course, anytime anything is FDA approved, I think the use of it expands both in inpatient and outpatient settings. I think, of course, that's true. However, I don't think a lack of FDA approval would necessarily be a barrier in any way to it getting utilized if there's clear studies showing that it works. If you look at combination therapy in psychiatry and the dosing in psychiatry, most of it is technically off-label and not in FDA-approved dose ranges or anything. But that doesn't stop psychiatrists from doing it. As long as they have clear data that shows it works, eventually it becomes the standard of care to use X combination or to go above recommended doses. So would FDA approval? Of course it helps. How could it not? But ultimately, if people see data that it works, then they're going to use it, regardless of whether it's FDA approved or not. And although ketamine is not FDA approved for depression, it is FDA approved. It's not an experimental drug. It's already approved. It has a safety profile and everything. So I think people just need to see it works, and that would be enough, whether there's FDA approval or not. That's what I think. That's what I see. Like I said, most prescribing is off-label anyway, technically. So.
Okay.
I agree.
Yeah, that's helpful. In terms of like clinical trial design, if a trial were to be run, I'm wondering if you have a perspective on what the relevant endpoints would be, and whether you view like I guess an avoidance and relapse of suicidality as a meaningful endpoint.
Yeah. So this. Okay. So we would be talking about people with bipolar depression specifically.
So it would be patients with bipolar depression who, it would be for the acute treatment. Sorry, for the treatment of acute suicidal ideation and behavior in patients with bipolar depression.
Yeah. Well, then I would think remission. Yeah. I mean, there's lots of relevant endpoint. I mean, I think remission of suicidal ideation would be one. Time to remission of suicidal ideation would be another. And I think exactly like you said, I think it would be totally relevant to have it if you're going to follow them, long term at least. Would be the endpoint would be, it could be like, of course, it could be number of people who have a repeat of suicidal ideation, but probably you'd expect everyone eventually to have. Unfortunately, to have suicidal ideation again, if you follow them long enough. So probably the better endpoint would be time until the suicidal ideation returns. Because that's what they find. People with bipolar disorder, no matter what they're on, eventually, if they've had suicidal ideation in the past, they're most likely going to have it again at some point. Maybe this would be the miracle cure, but probably nothing is. So if you could extend that out and say, oh look, they did get suicidal ideation again, but not for a much longer period than they went much longer without suicidal ideation, without a return of it than compared to most other things or all other things like lithium or whatever. Yeah, I mean that's a very relevant endpoint. And other endpoints, of course, can just be measuring general symptom reduction. They have like scales to measure that. So of course those can be clinical endpoints as well. You can also say like time to next mood episode. So like time to next, how long did they last until they had their next depressive episode? How long did they last until they had their next manic episode? I think all of those are relevant endpoints. And of course, if it proves, more rapid than other treatments, or more effective, or has fewer side effects than any of those, makes it like it gives it a viable place in the marketplace, I think.
Okay, that's helpful. And just, for your awareness, the endpoint that's being considered is avoiding relapse of suicidality and depression as defined by the number of days subjects are maintained relapse-free without experiencing or returning to pre-ketamine baseline levels of depression or suicidality. So sounds like that would be a reasonable endpoint.
Yeah, the number of days until relapse and that, I think that's the right endpoint, because to expect that they would never return to it would be setting any study up, not just this one, but any study up for failure, because I think no matter how well people are treated and, until we can like totally fix the brain, that symptoms are going to return at some point. So it sounds like a good primary endpoint when you're studying suicidality in this population.
Okay. I know we only have a minute or two left here, so I got just one last question aimed at trying to understand the the scope of the problem or the scope of the impact of suicidal ideation in this patient population. Would you describe most patients as experiencing this or presenting with this at some point in their disease course, or is it a cohort of patients or a subset of patients that are most likely to do so? And it does sound like patients who do present are likely